Hello, my name's Lynn Jones and welcome to the Motivational Midwife. Today we're going to have a little bit of a whistle-stop tour around hemoglobinopathies. So we're going to look at hemoglobinopathies. These are a group of recessively inherited genetic conditions and they affect essentially the hemoglobin of the blood. So recessively inherited means that it's not the dominant gene, it's a recessive gene. So it's at the back. And what will happen is if you have, in order to have the disease or the disorder, you need to have got the faulty recessive gene from both parents, one from each parent. If you only have one of them, then you are likely to be a healthy carrier of whatever disorder it is. It's not gender linked and it is more prevalent in some parts of the world than others. So hemoglobinopathies will either affect the quality of the hemoglobin, so they're things like your thalassemias, alpha and beta, or the quality and structure of the hemoglobin, and that will be things more like your sickle cell disease. So thalassemia much more common in Asian and Mediterranean countries, sickle cell disease much more common in West Africa and India, although widespread travel and intermarriage mean that we see a lot more of it now than we maybe used to 20, 30 years ago. Alpha thalassemia, really with all the thalassemias, there's a defect in either the alpha or the beta globin chain. And what that results in is thin, short-lived blood cells. They're often misshapen and they're deficient in hemoglobin, so that will lead to anemia. So with alpha thalassemia, there's been a complete deletion of the gene cluster, and that will result in a condition called hydrops fetalis. It's normally incompatible with life, and hydrops is where the fetus or the newborn really has excessive fluid. It becomes extremely oedematous, and if it does survive, it can have blood transfusions and some other treatments to try and reduce that fluid. However, they really generally don't survive very long at all. Beta thalassemia trait is where there is one copy that is correct copy and one of a faulty copy, and so these would be your healthy carrier because you need two copies of the faulty gene to actually have the disorder itself. Beta thalassemia major, on the other hand, is a very severe, debilitating illness. They've often got quite a short lifespan because of this life-threatening anemia. They have better lifespan than they used to because improvements in treatments have made things slightly better, but still, all in all, it's really not a hugely long lifespan for these individuals. They'll have monthly blood transfusions, but because the iron is not excreted terribly well from the body, what you will find is they get iron overload, which will then eventually lead to multi-organ failure. Sickle cell disease or sickle cell anemia is really linked to the ability to the oxygen carrying capacity of the hemoglobin. Okay, so when the cells become deoxygenated, instead of being a sort of donut shape, they change shape. So because crystals form within the cells, and then those crystals become quite stiff and rod-like, and cause the cell to become sickled in shape, so it's kind of like crescent shaped. When the cell gets back to the lungs and re-oxygenates, the shape will return to normal. The problem with this repeated sickling and unsickling is it causes a loss of water and potassium, and also damages the cells quite a bit, and those irreversibly damaged cells get removed, apologies for the spelling mistake there, from by the spleen, but that breakdown, that hemolysis, is very much accelerated, which will lead to a hemolytic anemia. Those cells, when they are sickled, so when they're in that crescent shape, they rupture very easily, and then, so they break, they rupture. So you have those lodging in blood vessels. So when we're looking at sort of signs and symptoms, particularly of sickle cell disease, if we're thinking of thalassemia, really it hinges mostly around sort of anemia, and women who have got our alpha thalassemia trait can probably generally just be monitored quite closely, and they may have normal antenatal care without very much else input. Beta thalassemia may require some iron supplementation. With sickle cell, it's present from birth, but it's very rare to see any signs and symptoms much before the baby is 6 months old. And some of the things that will present would be severe anemia, recurrent infections, strokes. You may have heard of the term sickle cell crisis, and this is really when they have severe pain because of that lack of oxygen in the cells and the sickling, and those sickle cells blocking the small blood vessels. It causes that severe pain, and the attacks can be anywhere, but are often predominantly chest, abdomen, back, jaws, legs and arms, and it is a really severe pain. Things that will cause the oxygen levels to drop will exacerbate this. So we're thinking of exertion if they were in high altitudes, if they become dehydrated, pregnancy itself, any sort of illness. So if we were looking at screening and treatment for both these conditions, but particularly for sickle cell, a multidisciplinary team approach is needed, and all women are usually have a family origin questionnaire to complete at booking, which will highlight whether they are at higher risk of having thalassemia or sickle cell disease, and if they have, their blood will then be screened to highlight that. It is something women have to consent to. For the pregnancy, routine antenatal bloods and booking bloods will be done, but they'll also have electrophoresis and liver function tests as well. Really important to have a urinalysis every visit, because pregnant women per se are more likely to get urinary tract infections, but these women, we've already said, are very, very high risk of infections, and urinary tract infections very common. We need to be aggressively treating any infections they get. So if they get an infection, really we're looking at a quick treatment with a broad spectrum antibiotic until you have the results back of whichever test you've sent off, so that you can have a infection specific antibiotic. Folic acid is encouraged for the whole pregnancy, not just in that sort of early pregnancy period. And generally they wouldn't have iron supplementation, because we don't want to have iron overload. So if they become very anemic, it's likely to be a blood transfusion that is needed. Now, if you think physiologically to those sickled cells that are easily ruptured and blocking those small blood vessels, then obviously we are at increased risk of VTEs, of venous thromboembolism. So low dose aspirin is often prescribed for these women in pregnancy. They're also at increased risk of preeclampsia. So we need to be thinking as well, these ladies are more at risk of placental abruption, placenta previa. They have a higher incidence of hypertension and preeclampsia, we've already said. They've got higher incidence of VTE, we've said. They do have a higher incidence of hypoperfusion of that placental circulation because of the sickling, which can then lead to your fetal hypoxia and a growth restricted baby. So close monitoring is really indicated for these women. They should be encouraged to deliver in an obstetric unit because we've said earlier that the things that can trigger a sickle cell crisis is dehydration. We really need to ensure that these ladies are very much hydrated in labour. So if they've got nausea and vomiting, we need to make sure they've got IV access and IV fluids going in. Pain can also trigger a crisis because labour can be quite a stressful event for women generally. So epidural is often recommended. We try and avoid a cesarean section unless it's clinically indicated because of these women's higher risk of infections and VTEs. 6-hourly bloods in labour to keep an eye on what that HB is doing and packed cell volume as well. Pulse oximetry throughout labour to make sure their oxygen saturations are staying within normal limits. And then when they have delivered, we need to really have close postnatal observation, particularly for signs of infection and VTE. So on that note, obviously you would encourage them to be mobilising early, have TED stockings on, keep them hydrated, encourage breastfeeding because then they will keep themselves hydrated as well. And before they go home, have a discussion around contraception as well. And there you have it, haemoglobinopathies. I hope you found that helpful. And if you haven't subscribed to the channel already, please do so. And I look forward to seeing you next time.